and symptoms are concerned for possible insulinoma.
Okay, insulinoma, yeah. And then what's the test to diagnose insulinoma?
You can check serum insulin levels,
Yeah.
C-peptide levels.
Yeah, so ideally with a 72-hour fast, if there's any equivocal results, you do a 72-hour fast, and then there's the 6 criteria, but basically it's high insulin, low glucose, Whipple's triad. We've kind of all been through that. So, and then what imaging tests would you use to start?
So for imaging to start with, I'll get a CT scan.
Okay. Anything specific about that CT scan?
With contrast, obviously.
Yeah.
Early.
Of the abdomen, yes. So a three-phase pancreas protocol, which we kind of all take for granted here. And then EUS is also helpful for insulinomas. These will often present with small masses, so CT may or may not pick them up. And then what imaging test is not reliable for insulinoma?
Some other stuff.
Yeah, TRIA scan. So it's more like a kind of a trivia question rather than anything. All right, and then what's the first therapy you're going to do for insulinoma? This is kind of like one of those trick questions before you do surgery.
Well, make sure that there's glucose, optimize.
Yeah, so generally use like a somatostatin analog first to try to level out their sugars, that kind of stuff, before you go to surgery. So on CT you see a 1.2 centimeter mass. It's in the head of the pancreas. It's away from the main duct. How would you treat that?
Number of options. Given the small size, one could elect to watch it.
Okay.
It's less than 2 centimeters, so.
So you're really going to watch an insulinoma though, right? This
But
lady came in with symptoms and problems.
So no, that's not actually.
Yeah.
Yeah. So it could be enucleated.
Okay. So yeah, that's probably the treatment of choice for this is enucleation. So for non-functioning, we'll talk about that, but small non-functioning, certainly you can observe, but someone who presents with symptoms, you're going to do something. So this is away from the duct in the head of the pancreas, so I think enucleation is the choice. So what if it was in the tail, out by the spleen?
Just in a tail, you could do just open protection.
Yeah, I think enucleation is still an option, or a spleen-preserving, probably distal pancreatectomy. So you probably don't need to take the spleen out. 90% of insulinomas are benign, so you can probably leave the spleen in if you have the ability to do that. And the point that I kind of tried to bring up was that people think that enucleation is better, but if you're going to do a small distal pancreatectomy versus enucleation, the distal panc might actually be lower morbidity because the leak rate could be higher. This is kind of depending on the reports, but the leak rate could be higher for enucleation. And then what if it's a deep lesion on the main pancreatic duct? Then how do you treat that?
Where is it located? Is it in the
Say
head?
the head.
It's in the head, and he's symptomatic, then we'll have to discuss a Whipple procedure.
So I think the answer is a Whipple, although you try to avoid that for insulinoma. And then these are the NCCN guidelines again. So first thing I think, something I never think about is stabilize the glucose first, and then again you can do.
How about, because we have this question at the board exam, we have a functional insulinoma with liver metastases that are resectable and it's in the head.
Yeah, we'll get into that, but I think it's a good question. So I think, I think you would try to resect all disease. You could try to.
Because sorry to metastasize, would you enucleate with liver resection or would you do a Whipple with liver resection?
Yeah, I think that in that case, I would argue that you need to get lymph nodes, right? Because it's metastatic now. So I would say a formal resection. But again, I wish Dr. Lee was here because I think it's a very interesting question, not an easy one. But I think.
Well,
I don't know, because you could say you could.
Yeah,
already metastasize to the point of like getting the nodes is like trivial, so you would enucleate and not do this. It's pretty morbid to do a Whipple with liver resection.
For sure.
So actually, like, there is no consensus.
Yeah,
So it's
yeah.
pretty interesting question.
Well, when Dr. Lee gets here, let's save that question. All right, so this is one of the SOSAP questions. Andrew, you're up. So it's basically a 2.2 centimeter non-functioning neuroendocrine PNET, a non-functioning PNET, in a 45-year-old healthy woman. guess we could take a vote on this one since it's multiple choice. So the choices are basically observe, enucleate, do a Whipple, only if lymph nodes are negative on frozen sections. That seems wrong. Or systemic therapy. So 45-year-old healthy woman with a 2.2 centimeter non-functioning neuroendocrine, who's going to observe that?
You didn't say the. It's well differentiated, right?
Yeah, it's well differentiated. Yeah. So not many people observing.
I would have the discussion to observe.
Yeah, I would
Okay.
Yeah, there's a lot of data for like bigger tissue.
It's close on size.
Yeah, so that's the issue, I think. So who would resect this? On your oral boards, who would resect this?
Hotel room? Yes.
Yeah, in a hotel room, I think you should resect it. So I think the NCCN guidelines are very clear. 2 centimeters is the cutoff. Whether that's real, again, the MSK paper went up to 3 centimeters, and they observed those patients, and the other paper went up to 4 centimeters. So size alone from the retrospective data is not a criteria, but for the NCCN guidelines, I think it is. So I think in the boards, you should resect this. In real life, I agree, you could probably observe it. So that's here, I think. So again, larger than 2 centimeters, the NCCN guidelines doesn't really equivocate. It says resect with nodes. So what if it's a 75-year-old woman with AFib, COPD, and now it's only 1.2 centimeters? Is anybody going to operate on this? No, everybody's going to observe this, right? Oh, there we go. And, all right, so less than 2 centimeters, observation is an option. All right. So, and I think, I think it's a tough question if it was 2.2 centimeters in that sick old person. I think you have to at least consider observing. So I think hopefully they won't ask that on the boards. That would be tough. So again, this is that study I talked about. This is less than 4 centimeters. And then the MSK paper is less than 3 centimeters. All right. So, New Hook, can you read from back there?
Yes.
This is the smaller print
43-year-old
too.
male with pancreatitis. Why is it so small, Ted?
I don't know, because this is from Jordan's slides. This is his print was smaller. So they presented with pancreatitis. It's a non-functional PNET, well differentiated, low Ki67. It's 1.3 centimeters.
Okay.
What do you want to do? Labs. So that's something we didn't talk about.
Didn't we already get all these labs?
Yeah, sorry, I skipped ahead. So that's something we didn't talk about in the last one. You should draw like some basic labs. What would you draw just to rule out basic things?
So in terms of other functions, so like
Yeah.
you mean like insulin levels, C-peptide.
Okay, so just insulin
serum
level is probably enough.
gastrin.
A fasting serum gastrin.
Yeah,
I think that's really all you have to do is rule out the 2 most common. And you don't have to go down that algorithm. Just get the basic stuff.
I mean, a lot of it's been listed by history too.
Yeah.
Okay.
All right.
Next question.
Imaging.
Let's start with a CT pancreas protocol.
Okay. All right. So you have this 1.3 centimeter hypervascular mass.
Is that not isn't it?
Yeah.
Bad spot, so that's hard to That's 1.3 centimeters.
And it caused pancreatitis.
Oh, I didn't need this. So symptomatic.
Yeah. These are supposed to be difficult questions, so Dr. Lee could help us work our way
Any
through
other
them.
risk factors for pancreatitis?
No.
So it's clearly this.
Yes.
Does ductal dilatation on his CT?
It does not. So at least on these cuts.
No, does that say no nodes up there? No, it says.
It doesn't, but oh yeah, it does. No notes.
This is tough. I really want to watch it, but it's symptomatic. And I think that I would try to actually, if it's away from the duct on the posterior side, I wonder if you could enucleate that with a full coker. But if you can't, then
Just wonder why it would cause pancreatitis if it was away from the duct.
that's true. So it's in the intersection.
I think so. Yeah. I was really hoping Dr. Lee would be here for this case.
Am I crazy? Would everyone else respect that? Symptomatic?
I think you're forced to, yeah.
That is
I mean, it sucks because it's 1.3 centimeters.
Yeah. I think if you take
I like
away,
your idea about trying to get to it. Is
you
it
could
possible?
get to the posterior side of it, but you know,
Ultrasound and
It'd be
say
tough.
you drop. I think you're gonna too close.
and I think if we take away the pancreatitis, everybody agrees we would watch that. So, and then what if it was easier to enucleate, and maybe let's take away the pancreatitis.
take away the pancreatitis and still watch it.
Yeah, so I think you could watch it still. What if there were concerning findings for lymph nodes on the CT scan?
I would see if they're amenable to biopsy for a PNET. I'd probably biopsy them if they are easily biopsiable with EUS. If they're not, then I'd do resection.
Yeah, so I don't think there's anything in the literature to support that. I think it's
For which one?
to support like an EUS biopsy of these
Really?
concerning nodes, because all the studies that talk about observation, they're very clear that there's no concerning imaging findings. So I think that most people, if there's concerning imaging findings to include the lymph nodes, you could enucleate and then do a nodal sampling rather than doing a Whipple.
Oh, that's good.
But I think I think it's something to ask Dr. Lee, because
Well,
So
I get that in overall, but in a, you tell me that this is a no pancreatitis in a non-enucleatable location.
yeah. I think the problem is if your lymph node sampling is negative, are you going to feel comfortable sitting on it?
In a 1.3 centimeter asymptomatic lesion, yeah,
Okay.
probably. I'd feel more comfortable doing that. But if there's, a lot of diffuse lymphadenopathy, I mean, are these things, do you do like a PET?
Yeah, go ahead.
Yeah, you do
Yeah,
a
so
PET
you
thing?
could. That's another. You could use dotatate as a tiebreaker. I don't think that's a bad idea.
Something's not lined up with a 1.3 centimeter lesion with
Well,
asymptomatic.
that's also not really true, right? So some of these present with liver mets and positive nodes, even though they're small. So
No, I understand that. It's a spectrum disease. It's just not adding up in terms of algorithm. I'm just thinking out loud, guys.
sure.
If you enucleate it with the nodes and the nodes come back positive, you go back for a Whipple.
No, you just kind of know that they're at higher risk. All right. Where's Dr. Lee? So left side of the lesion, what would you do if it was in the tail?
It's 1.3 centimeters.
Yeah.
Asymptomatic.
What if they have pancreatitis now?
I'd do it sling through.
So yeah, you feel better about resecting.
These things that are not anywhere near the duct or vessels cause pancreatitis. Like why?
Probably not. Yeah, I know. So I think that's true. Like I think that's why the symptoms make you worry, because if it's causing pancreatitis, the ability to enucleate it is probably
Yeah.
0 because it caused pancreatitis. It has to be near the duct. So yeah. It'd be better if Dr. Lee was here. All right, so another simple case. So 45-year-old female, vague abdominal pain. That's how most of these present. So this is out in the tail, way out in the tail. But there's a questionable liver mass on her CT scan. So biopsy shows. So you did a US biopsy. It's a well-differentiated PNET. What would you want to do next?
The biopsy of the liver or the pancreas?
Pancreas, sorry. So the liver thing is not it wasn't biopsy.
Get a better characteristic liver.
Yeah. So what would you use your tiebreaker here? What other imaging could you get? We kind of just talked about it.
Which
So,
about
yeah.
X-ray scans.
So I think dotatate is the answer in 2018. Actria scans are
Okay.
really not done anymore, and the reason being is that the imaging is better because it's not SPECT, it's PET.
Sonic ray.
And so you get, yeah, I think that's a problem. But I think it's getting better because now that PRRT has been approved by the FDA, that's becoming a little more widespread, and I think insurance companies are going to come around to it. And there are multiple studies now showing that it's more sensitive than Actria scan. But that is a problem. Dr. Lee mentioned that when I talked to him about it, that getting insurance to cover it is definitely an issue. But if you could get a dotatate scan. So this is one dotatate scan just to give you an idea of what they look like. So again, they're PET images rather than SPECT, so they're a little bit sharper. So let's say this is what we saw. So we have this thing in the tail, and now we have this in the liver. Emily, since we were talking, you can go. So I'm just going to go through kind of these combinations and how you would manage them surgically. So you have resectable PNET in the tail, and then you have this single 1.5 centimeter liver met. Emily, what do you think you would do for that?
So I probably do a distal tank and I don't know, like a
Some sort of partial
Like, yeah.
hepatectomy, same time.
Yeah.
Okay. Yeah. So yeah, I think with distal and a partial, you can do them at the same time. And then so now this is the liver. So
You're getting spleen. You're getting to take the spleen, right? You need the nose.
Yeah. For something that big, and with Mets, you know it's coming. So, so now you need a distal, but you also need a major liver resection. What do you think about that?
sorry, is this symptomatic or no?
It's no, but it's 4.5 centimeters and it has metastatic disease. But it is resectable. It's just going to require a major liver resection. Scally, any thoughts? You look like you have
I
thoughts.
already gave you my thought.
What?
Give him the Steve Jobs treatment.
I don't know what that means.
This is like exactly what Steve Jobs.
Oh.
There's an app for that.
Oh, this is like, oh, I get it. Well, you look like you have thoughts.
I mean, I think a young patient could give some consideration to it, but probably want to see some test of time before committing to a major hepatectomy.
Yeah, so I think here this patient gets neoadjuvant all the time. So that's not something that's well described in literature at all. But here they often give like a streptozocin-based neoadjuvant chemo and see whether or not they respond or they, progress. The response rates in the literature are low, less than 50%. So this patient's not going to have a dramatic response, but you could potentially kind of slow their disease. The other options are all those other things, right? So everolimus, sunitinib, lanreotide have all been shown to slow progression. So you could just give them some of that and see if their tumors kind of stabilize, and then go operate. Now, if you were going to operate on this, would you do it all in one, or would you stage it? Yeah, I think stage. So I did one distal with Zong that was like this. The guy had a bunch of lesions in his right liver, and we did the distal pancreatectomy with plans to come back, and he was on lanreotide in between. And the thought process is that one of the biggest risks for post-hepatectomy liver failure is sepsis. So if you get a leak from this and then they get an abscess and they get sick while their liver's trying to regenerate, that can lead to a high mortality rate. So I think there's not a lot in the literature about this. It's actually something I've thought about that we should look at here because we probably have an experience of it that most people don't, of staged liver and pancreas resection. Anyway. So now what if we have a 4.5 centimeter PNET in the head and this little distal liver met? Perry, what do you think? Get the European perspective.
Otherwise healthy.
Very healthy, no medical problems.
I think this could be combined for both liver and pancreas surgery.
Yeah, I think that's true. I think if you don't need significant regeneration, I don't know how to define that, but if you're not requiring the liver to regenerate in any significant way, I think you can combine them safely. In one of the cases Dr. Lee brought, they actually did that. So they did a Whipple and a partial. So. And then
For
if it's
the other case, the indication for transplant, when would you consider that?
so can you hold that till the very end? So Dr. Lee has some slides that I stole, and he briefly talks about transplant. Yeah, I think that's an option. It's like I think on protocol very early, but that is something that people do now. But that I will say that the idea here is that you could just do it right and clear all their disease. So I don't know that they need a transplant. But if it was truly unresectable liver mets, that's when you would talk about it. And then, so if they need a Whipple and a major hepatectomy, that's probably bad. Don't do that at the same time. But I think doing neoadjuvant and seeing maybe some response, and then potentially doing a multiple stage procedure is certainly a possibility. So this is just a paper that we're working on with Dr. Loy. It's a NISQUIP paper where we looked at combined liver and pancreas resection. So basic we defined as a partial hepatectomy, distal pancreatectomy, and then major as a major hepatectomy, distal panc, or a partial, like a small liver resection and a Whipple, and then radical would be the extremes of both. And the bottom line is that the mortality is high with these radicals, about 10%, and then the grade 3-4 complications is over 50%. So, as you might imagine, these are very morbid operations if you combine them.
For neuroenterprise?
So it's NISQIP, so we don't know. It just says malignant pancreas, but we're presuming that if you're doing a combined resection, it's probably for a PNET. There were certainly some cholangios probably too, where you're doing, where you have to take both at the same time. But, so we don't know for sure. We know cholangios, but the pancreas is classified as malignant pancreas. So that was one of the reviewers' comments.
It wasn't made.
But you presume it's not pancreas. You presume it's not adenocarcinoma. All right, so this is one of Jordan's cases, I think. So 34-year-old diagnosed with MEN syndrome at a young age. This is kind of a gee-whiz case. There's not a lot of questions. So they've had all these different things. So they had two. Actually, I'm sorry. This is Dr. Lee's case. Yeah, sorry. So this is. So anyway, MEN 1 patient had a parathyroidectomy. They have a pituitary adenoma that's being treated medically. They're just watching that. Surveillance CT scan initially showed a small mass in the tail of the pancreas. Repeat scan in 15 showed these two masses, a 2.2 centimeter and a 7 by 7 millimeter mass. And then these were watched. And then a little bit of growth in the mass in the tail with now extension into the surrounding fat. So that's a concerning imaging finding. And then the one in the uncinate has grown just a small amount too. So what would you do for this patient? Where are we at? Sarah.
Sorry.
That's okay. That's okay. So it's a MEN 1 patient with.
They followed the pancreas mass, and then now it's growing.
It's growing a little bit, and now infiltrating into the peripancreatic fat.
The one in the
tail.
One
in the tail is.
And the one in the uncinate is still going.
Yeah, small.
I'd consider talking to her about a distal panc, but I'd leave the head lesion alone.
Okay.
She's gonna have others.
So these were non-functional. So they tested all this stuff, non-functional. And then she had a dotatate scan. It's kind of subtle, but this is the one in the uncinate. This is the one in the tail. So USFNA was done. Both confirmed to be PNETs. And so I think you brought up a good point. This is MEN 1, so it's likely to be multiple. So whatever you do in the operating room, you're going to do an EUS as well and look for more. So I was really hoping Dr. Lee would be here by now because he took her to the operating room and tried to resect both. So she was taken to the operating room for an open distal pancreatectomy with intraoperative ultrasound. Multiple biopsies were taken of the area that was biopsy confirmed PNET in the uncinate, and nothing, it was all benign. So the second PNET was never found. Ultrasound was done, nothing else was found. There was a little bit of a cystic area on ultrasound where that biopsy had been done, and that's where all those biopsies were taken. Nothing was ever found. So post-op, she had a leak. This was controlled by her surgical drain initially, but she was readmitted. And I think this is kind of an interesting point. She came back with fluid on the right side mainly, and that could just be because the surgical drain didn't drain it well, but I think she also could have potentially been leaking from all those biopsies too. So, taking that patient and doing a nucleation of the head is not benign and can cause leaks. So
It was not benign. It was not benign.
that was Newhook did that. Newhook did that. All right. So I don't remember what this case is about. This is one of Jordan's. Zag.
We went through it already
You
together.
did?
Yeah.
Oh, well, it's fine. You don't know the answer then. I don't remember. You remember?
Actually, I think we skipped this one.
Exactly. All right, so 7.5 centimeter in the head of the pancreas, 3 nodules in the liver. Biopsy shows well-differentiated neuroendocrine neoplasm.
I think our conclusion.
Oh, this was, sorry, this is Dr. Lee's case.
Yeah.
So So, so this is what we were talking about. So this patient got a Whipple and then got chemotherapy afterwards. An intraoperative ultrasound during the Whipple showed multiple lesions throughout the right liver and into segment 4. So they were going to need an extended right hepatectomy. So they did a PVE on this patient. So Whipple, chemo, PVE, and they were able to grow the liver enough to go back later and do a right trisect. So I think this is the extreme, but this can be done. And the patient apparently has no recurrence at almost 2 years out. So that's good. So those are the extremes. And then this is Dr. Lee's data from here, which I don't know, and he was going to present. So maybe when he gets here, we'll talk about that. And then another case, Diego. So this is another PNET. This is a huge PNET. Involves the spleen, posterior wall of the stomach, left adrenal gland, with tumor thrombus into the portal vein. What do you do for this patient?
So the usual workup.
Yeah.
Rule out, make sure non-functional, all that stuff.
Yeah.
But then they're getting some form of neoadjuvant here.
Yep.
Trying to get it off the vasculature. And then there's some data about doing these tumor thrombectomies here, which I'm hoping you're going to cover because I don't remember.
Where do you think that data came from?
I thought it was here.
Yeah, it came from MD Anderson. So this is a patient that was done here. So they got pre-op chemo, 5-FU, streptozotocin, doxorubicin, stable disease, so they didn't have much of a response. And I think that's pretty common. These don't melt away with chemo. But they got a distal pancreatectomy, splenectomy, left adrenalectomy, partial gastrectomy, cholecystectomy, and a portal venotomy with tumor thrombectomy. So there's this report from here where there were, I think, 10 patients that had tumor thrombectomies and did well. Dr. Lee, do you want to? Dr. Lee, do you want to present the data from here? I slid this in from your slides.
No, go ahead. That's
Okay.
fine. Yeah.
Well, we're almost done. So.
Yeah.
But we have some questions saved up for you.
Did you? Yeah.
Ed, what was remember your question?
Yours was the Whipple. So the.
Oh yeah, it was in your first case where you talked about different scenarios of insulinoma.
Yeah. So insulinoma with METs in the head of the
if you have like a
pancreas.
small insulinoma in
actually
the
have
head
a
of the
slide.
pancreas, it was like a board exam, maybe board exam
Yeah.
question. If you have a small insulinoma with liver metastases, the debate was at the time, would you do the liver resection with Whipple or enucleation and liver resection since the patient already metastasized? Was the point of taking the nose at that point? And so we divided between
Yeah.
the two strategies,
Yeah.
given the morbidity associated with Whipple
Yeah.
plus liver resection.
Yeah, I think that's a good question. I think so. The data from here, I think, and elsewhere demonstrates that the combination of Whipple and liver resection has a high morbidity associated with it. And there are downstream risks as well sometimes with cholangitis and liver abscess and so forth. So although in selective cases you may not have a great choice. In a situation like that, if I had an opportunity to do an enucleation as opposed to a Whipple, and leave the ampulla in place and avoid reflux cholangitis and the combinations of the two surgeries, I would do that. I think in general, I would expect that if you have a scenario like this where you have a small primary tumor and established liver metastases, the likelihood with neuroendocrine tumor that you have occult nodal disease that hasn't manifested itself on imaging is smaller. I think in a situation like that, there are a few situations nowadays where I do think that now that we have the availability of dotatate scans and their sensitivity is so high at picking up neuroendocrine metastases, I'm not sure about insulinoma. I'd have to look that up, but I don't know how much data there is. But is so high that I might use that as an additional imaging modality if I could get it approved by insurance ahead of time. to reassure myself that I didn't have to do a concomitant lymphadenectomy at the time that I did my liver resection and enucleation. If I did have nodal disease, I might even consider doing a lymphadenectomy and leaving the head of the pancreas in place. It is true that you don't do as good a lymphadenectomy as you do if you just take the head of the pancreas out. We kind of know that from the MEN1 patient data, but you can do a lymphadenectomy and just strip all those lymph nodes. I wouldn't do that without evidence of nodal disease, but if I did, I might even consider doing something as sort of off protocol as that. But I think in terms of the board exam, I think it's completely defendable to do enucleation and liver resection.
And then if you had to, like in a non-functioning, we kind of went through these scenarios. If you had to do a Whipple and they had a liver met, what would your threshold be to do those, to stage those? Like if you do a little partial hepatectomy at the same time as a Whipple, that's okay, but a major hepatectomy you would stage and do a separate operation?
Probably. I think that it is a situation where it wouldn't be unreasonable to think about giving something up front.
Okay.
I don't. I think even if I think that's, even though I'm not sure I would give that answer on a board exam yet. I think you can't tell how the examiner would react to that sort of response. But given the morbidity of the combined operation, the fact that if you're going to stage the operations, you can be leaving half the tumor in anyways. And that's not terribly attractive, is it? So it wouldn't be, I don't think it would be, I think it would be reasonable to give something first and use the information about the biology of the disease. Is the liver blossoming? In other words, is the operation worth investing in for the patient before you did surgery? What I would choose, it's a good question. You're probably not going to get much downstaging with a somatostatin inhibitor. You could use a targeted agent. You could use chemotherapy. You could use streptozotocin-based chemotherapy. You're not really necessarily looking for tumor downstaging, though. You're primarily looking, to see what the biology of the disease is and disease stability. So I'd probably go with, one of the first two choices.
Then, like I had a case with Dr. Zung where in between they gave lanreotide just to kind of hold the disease where it was in between the stage.
Yeah.
So chemotherapy options. So again, low response rates, but it seems like here we do give this pre-op, usually streptozotocin 5-FU.
For pancreatic neuroendocrine tumor.
Right.
Remember that there's a big difference, right,
Sure.
in response rates. So, yeah.
And then, so this is that thrombectomy case. So this is another SOSAP patient or case, which I think will hopefully spur some discussion about these different agents. So 46-year-old woman, requiring abdominal pain. She has bulky tumors throughout her liver. The bottom line is she needs medical therapy. And the SOSAP question, which I think is sort of, I don't know, I think it's difficult to name the right answer here. Which of the following therapies would be most likely to palliate her symptoms? So long-acting somatostatin analog, daily oral sunitinib, weekly IV bolus of 5-FU with cisplatin, TACE, or administration of radiolabeled somatostatin analog, so PRRT, which is that new therapy. So I don't know. I think, Dr. Lee, I think the answer they're looking for here is A, because that was FDA approved for symptom management specifically, the long-acting octreotide?
Yeah,
And it's
I'm
probably
not,
an old
I'm not
question.
sure that I'm not sure I agree with that either. So the what I would say is first of all, I would ask the question, what is her symptom? And her symptom is from Mass Effect, right? So that's not going to be well palliated with somatostatin analog. You would expect, because it's not likely you're going to get a huge amount of
Massive
downstaging. So I'm not sure that A is actually. Do you know what the answer is that they're looking for?
I don't.
So I'm not sure that they're really looking for that answer.
Yeah.
Now you know it's PNET, so you know you could say chemotherapy, but you're not. They don't give a streptozocin-based choice. So, and plus that's temporary. That she may get palliation, but you'd expect it to be temporary. So I'm not sure I like A, B, or C. Now there's recent data that suggests that maybe radiolabeled therapy in combination with somatostatin analog can be effective. But again, I think probably what they're looking for is chemoembolization here, to be honest with you, because I think what they're looking for is
The Mass Effect.
is the best durable palliation of the mass effect of the tumors.
Okay.
What do you have? You're shaking your
I
head.
agree. No, I agree with that, especially when you have a liver-limited metastatic disease.
Right.
So you're not like burning bridges by using. You want to keep tools in your back pocket since it's a more indolent disease.
Sure.
So not necessarily jump to sunitinib or other more systemic options. So you have options in the future down the road.
So that's what I think they were looking for here.
So in 2018, what do you think the go-to is? So like sort of in the video I went through, like there's all these trials.
Right.
And there's the NCCN guidelines are completely useless, no help at all.
Right.
And now PRRT,
Yeah.
is that going to become the treatment of choice?
I do think that it's going to become fairly popular. Yeah, based on the trial results. And it may be that it'll be used for a while, and then we'll discover what the limitations are. It won't be as attractive as the trial results would suggest. But I have even when I present this data and go through it myself, I have challenges thinking about how to order the therapies and how to choose them. It's a sort of thing that some of you probably have heard Dr. Yao talk about these things, and he is so smart and so thoughtful about them. But it's based really on, sometimes it's based on whether the trial, on what the trial population was for the therapy. In other words, he will, if the therapy was, whether the trial population was PNET or carcinoid or mixed, he'll favor one or the other or use it for both populations. Sometimes if a subgroup analysis seemed to, or based on side effect profile, it gets to be a very medical oncology type judgment issue. It's not straightforward. We don't have enough data head to head of these therapies to really allow us to be completely intelligent about how to choose therapies. The good news is we have multiple partially effective treatments. The bad news is just like in melanoma right now, we have lots of opportunities for therapy, but we don't know necessarily how best to combine them or to sequence them. And we use soft call judgment to make those decisions. Indolent disease, not a lot of physical symptoms related to the disease, but potentially hormone-related symptoms, and somatostatin analogs tend to be favored until they stop working, or we need to add something else. We don't always stop them when we add a second therapy, preserving chemo for PNETs with where you have bulk disease and you want downstaging, but not depending on it for longer periods of time, using more aggressive disease or after failure of therapy, some of the targeted therapies that we have available. And for liver dominant disease, considering some either chemoembolization or radioembolization.
Now, will this cause inflammation will make operations more difficult because it's radioactive?
That's I think the anecdotal experience.
You wouldn't give this
that.
preoperatively.
I don't think it's. Okay. I don't know if Nick or any of the liver surgeons have experience with it, but I don't know. I think that the experience with surgery after this agent is really very, very limited.
One thing James Yao told me is that bulky liver disease, you have to be careful with PPRT because it can give a patient liver failure.
John, what was that? Sorry.
Yeah.
He told me that James Yao was in clinic with him once. He told me that with bulky liver disease, PPRT can cause liver failure. So something that can. You have to think about that.
Then, Dr. I just wanted to get your opinion on this somewhat busy slide that I stole from Jonathan from one of the recent endocrine talks, but I think it sort of breaks down nicely the basic surgical management.
Yeah. Where'd you get this, Jonathan?
Dr. Chabot gave a talk, so I took a picture of his slide.
Nice. Dr. Abruzzi's was the chair of GI medical oncology here before Dr. Yao, and he used to say, "I hate guidelines." He really was allergic to guidelines, and no sooner do you put up a diagram like this for a disease, for really what is a group of diseases, right? We recognize that this is not a single cancer; it's a really diverse group of diseases that you recognize the challenges and limitations of a diagram like this. So it may be helpful as a starting point, but I think what I would hope that you guys would understand, given your advanced training, is that the patients are not necessarily going to fall into this diagram. So if we go over to the left side, for example, and look at greater than 2 centimeters near the pancreatic duct, no, enucleate. Well, we know that we're not going to enucleate every 3 centimeter, probably not even most 3 centimeter PNET, right? Even if it's functioning, we may enucleate a small one if it's favorable, but if it's out in the tail, there's no real justification for enucleating a distal tumor that's large, right? That the risk of a leak is higher in that situation than it is from just a straight transection overcell. So that just in a form, and you wouldn't make that mistake, but if you're looking at the flow diagram and seeing does this make sense, you would say that. So the other issue is it looks like you're only going to give medical therapy to high-grade tumors if they're metastatic, and that's not necessarily the best advice. High-grade neuroendocrine that's a bad disease, and even if you don't have liver mets at presentation, those behave like small cell lung cancer. They're much more chemotherapy sensitive. So if you have a PNET, let's say you've got I can't tell you how often I've seen, they just look nasty. You're not going to see a high-grade tumor that's not metastatic where you're going to say, boy, I'd like to take that out. in general. So I just would, what else? Maybe that's enough, just to give you the sense of.
That was one thing I found kind of confusing in the new AJCC manual, that there are these, if they're poorly differentiated, they're not even PNETs. But there are these
Right.
PNETs that are not poorly differentiated, but they are high grade.
Yeah.
And kind of what do you do with those?
Yeah.
Where do those fit in?
Yeah.
It seems like we don't have a good answer to that.
Yeah. Yeah. Fair enough.
But it sounds like they're very unusual.
Yes, they're.
And I think that actually the last case, this is one I kept from Jordan, but it was basically to show that point. This was a patient with an undifferentiated high-grade neuroendocrine carcinoma, small cell carcinoma. So this is basically not a PNET. So this patient is treated differently. And then the other thing is that on CT scan, they're not going to be hypervascular, so they're not even going to look like PNETs. They look more like adenocarcinoma.
And those tumors, they typically do at least have regional nodal metastases.
So anyway, they treated this more like a small cell lung cancer than a PNET. No surgery. They got chemotherapy and then consolidated radiotherapy. All right. I think that's all I had for cases.
We got through all the cases.
We went kind of fast because we didn't know any of the answers. So
Sure you did.
It might be worth it to go back through some of them. So this was something we kind of struggle with. So 2.2 centimeter non-functioning PNET. The NCCN guidelines tell us over 2 centimeters we're supposed to operate. Is that how you practice, or is that just how we should answer our boards? And then
yeah, the answer to the latter question is yes. You should answer the boards that way.
Right.
That would be the answer on this to this question.
Yes,
to operate on the patient, I think, and I think that I'm actually this summer I'm going to help develop some consensus guidelines on the management of patients with neuroendocrine tumors, and I've been asked in particular to address this issue of sporadic, relatively small PNETs. Under what circumstances should we observe, and what circumstances should we resect? What's the literature say, and what do we want to say as a consensus statement about these patients? I do generally use the rules of a centimeter or less, consider observation. 1 to 2 centimeters for non-functioning, consider individualized, and over 2 centimeters resect. And I think that's helpful as a starting point, right? And it's helpful as a starting point for your conversation with the patient too. I think so. In a young patient with a 2 centimeter sporadic non-functioning PNET, my default would be to resect, or at least start that conversation. The advantage that you have with these tumors, because they're relatively indolent, is you don't have to rush to the operating room, and if the patient needs time to wrap their head around the life-changing, fact of a Whipple, you can give them a few months to do that. You can put another imaging study in between the initial one, the discovery of the tumor, and your surgery, and not feel that you can reassure the patient that that's almost certainly going to be okay. But I think the default in this patient is you're going ahead to the operating room. If the patient is there, are there circumstances where I would observe a tumor like this? If the patient wasn't ready to have a Whipple emotionally, the patient had significant comorbidities or was elderly, a patient who had an inherited tumor syndrome, I think, MEN1, and you're trying to decide how much or what part of the pancreas you're going to take out with, for example, multiple tumors being present. You could wait a little bit longer since MEN1 mutations, either germline or sporadic in the tumors, seem to be associated with slightly more indolent natural history than other PNETs, and metastases generally occur at around 3 centimeters or so, or larger. I think a patient with von Hippel-Lindau and a 2.2 centimeter tumor, since those seem to be even less aggressive than MEN1 associated PNETs, you could have a higher threshold. In general, this will come out.
For the syndromic patients, like the von Hippel-Lindau, how frequently would you repeat imaging? 6 months? For 2.2 centimeter.
We actually wrote some relatively complicated guidelines into a recent paper on the MEN1 patients that integrates their mutation status, the exon of their mutation, with their with the information that you have from prior imaging, whether the tumor's getting larger or not, in order to put a plan together for whether you do imaging every 6 months or every year, let's say. And honestly, what we came up with was so complicated that I'm not sure I would even stand behind it. But one of the reviewers asked us, what would you do? So we felt obligated in revision to address the question. But we hedged a lot and said a reasonable approach might be to do this. But I think my initial default with a patient with either MEN1 or VHL is every 6 months until I have enough. I feel like I've had enough imaging, at least a year's worth, sometimes 2 years worth, in order to go to an annual follow-up. And I would only go to annual follow-up if the tumors are small, if they're in that, if they're 1 centimeter-ish range. Otherwise, if you have a 2 centimeter tumor, you're pretty much stuck with 6-month follow-up intervals.
And then pancreatitis. If one of these presents with pancreatitis, does that change your decision making? If it was under the 2 centimeter threshold that presented that way.
So the answer to that is maybe. So the answer to that is yes. The fact that it presented with symptoms, it doesn't make me more worried that it's going to be an aggressive tumor. It does imply that the patient may be more likely to have recurrent symptoms related to the local tumor and involvement of the pancreatic duct. I have to balance that against how serious was the pancreatitis. In other words, what is my operative experience going to be like trying to operate on that patient early after an episode of acute pancreatitis, and that's often from a technical standpoint in a situation where you don't think it's an urgent cancer issue. You're probably better off waiting a few months to let the pancreatitis calm down.
Would you do some kind of octreotide in the meantime or anything?
Not necessarily. Yeah, not necessarily. And the question is, then what's the octreotide for? Is it because of the
stabilize it?
Maybe. Yeah.
While you're sitting on your thumb.
I don't know. And it's an open question as to whether octreotide, like LAR, would be helpful in changing the natural history of primary neuroendocrine tumors. We don't know the answer to that, right? Either in the inherited or the sporadic situation. So I haven't used that. So what I was getting at is, you want to put a few months between the pancreatitis and the operation, but then the pancreatitis comes down, the tumor's small, patient doesn't have a recurrent episode of pancreatitis, then why are you operating on it? Why are you rushing in and operating on the patient, right? So you get into that circular argument about, obviously if the patient has recurrent episodes of pancreatitis, that could be a situation where I might put the patient on octreotide to try to just settle things down a bit. If they've had 2 episodes, put them on octreotide, or a smoldering sort of, then try to put everything to sleep and then operate when I think out of the window. That's the situation.
And then when are you using dotatate? Are you trying to get them all the time and they're not being approved, or are you using it when it's like questionable nodal involvement, questionable liver lesion, that kind of stuff?
So the answer is I'm using it when I think it will change the operative plan, right? So like we tried to get it in this lady that we did this past week, because she had a relatively modestly sized, like a 1.8 centimeter, and Annabelle can tell me if I'm quoting the data wrong on this patient situation, but had a 1.8 centimeter stable neuroendocrine tumor in the tail of the pancreas. She had, it was stable on serial imaging. She had no evidence radiographically of any additional disease. And this is a fascinating problem for me because I think surgeons who manage these patients they're not talking through the decision making that goes into how you manage that patient. So let's say it was 2 centimeters. She wanted surgery. She was nervous about watching it. We were headed in that direction anyway. She's relatively young. She's otherwise healthy. And it's a situation where you would either do a distal pancreatectomy splenectomy, probably laparoscopically, or you do a distal spleen preserving pancreatectomy. If you do the former operation, there's no question you're going to get a bunch of nodes, and it's probably not important to know whether the nodes are involved or not because you're going to be able to stage the patient based on the surgical specimen. But if you're dealing with a smaller tumor that you're thinking about enucleating, if you're thinking about doing a spleen preserving distal pancreatectomy, if you're thinking about doing a central pancreatectomy because you have a 2 centimeter tumor in the pancreatic neck, you're not going to get a lot of nodes unless you do a lot of extra surgery. And even then, that regional lymphadenectomy with a central pancreatectomy, you're going to be making it up, basically. If you do a distal spleen preserving, you're going to have to dig into the splenic hilum, and even then you're not going to get really adequate sampling. I don't know how to do that operation. So you're assuming that the patient doesn't have nodal disease or that the nodes really don't matter. And that's a situation where my preference would be to do a dotatate because of its sensitivity, specifically because of on the assumption that I might identify nodal disease that wasn't apparent on the CAT scans. That's totally an open question. That is just a push of the data beyond where it may be, it may be able to give us information. But that's when I ask to do a dotatate scan, and that's the most common situation when I'm thinking about doing, a limited surgical procedure where I'm just going to take the tumor out. I know that I'm not going to do adequate nodal sampling, and I'd like some reassurance that there's not likely to be any nodal involvement.
Do we have any other questions? We're about out of time. So. Okay. Thank you, sir. Appreciate it.
Sorry I'm
your time.
late. Thank you. Sorry I was late.